Morning, everyone, and welcome to this webinar by the Global Mental Health Action Network, powered by United for Global Mental Health. My name is Moleboheng, and I'm from Ways for Change, a South African-based nonprofit organization that provides mental health support for children and adolescents through sport, particularly surfing, to help them learn how to identify and regulate their emotions, as well as build social connectedness with their peers, mainly through physical activities. It's such a pleasure to have you with us here today. We know that you could have chosen to be anywhere else at this point, and here you are. So thank you so much for your time and tuning into this event. We do highly encourage you to introduce yourselves in the chat, the name of your organization, as well as the country where you are right now, so that you can connect with other people that are also tuned into this webinar. Now, for those of you who might not know what the Global Mental Health Action Network is all about, it is a network that aims to encourage greater global collaboration on mental health advocacy, and to also enable anyone with a professional interest in mental health or health policy to connect with others who share this interest. This particular webinar is part of a Mental Health for All webinar series that United for Global Mental Health has been running since April 2020. The purpose of the series is to explain and share updates on relevant topics and learn more from different people and organizations around the world on global mental health and its many intersections. And that now brings me to the topic of today's event, which is all about digital mental health. We will be discussing the critical role that digital mental health tools play in addressing service gaps, enhancing accessibility, as well as combating stigma. Now, to help us delve deeper into this topic, we are joined by an esteemed panel of professionals who work within the mental health care space, and they will help us unpack this topic with meaningful experiences and insights. But before we do that, before they introduce themselves, let me just give you a quick rundown of how today's session will run. So first, we'll get to know our speakers or panelists, and they'll tell us a bit more about who they are, the work they do within their respective organizations. After that, we'll dive deeper into the conversation about digital mental health for about 20 minutes. And then we'll have another 20 minutes where you, as the audience, have the opportunity to ask our panelists questions. So we encourage you to send your questions in the chat window. So I think now we can go ahead and get to know a little bit about our panelists for today. Dua, do you want to get us started and let us know who you are?
Hello, hi everyone. I hope everyone's doing great. So my name is Dua Nusrat, and I am a digital marketing and communication specialist. I am currently working at a nonprofit in Pakistan called the Skin Health Initiative, and I am the senior program manager there, looking after mental health awareness programs and advocacy. So essentially increasing mental health awareness in the region, reducing stigma, and also working with the government to increase financing for mental health in Pakistan. And I'm super happy to be here and looking forward to the discussion. Thank you.
Perfect. Thank you, Dua. And Antonio?
Yes, hi, I'm Antonio, and I'm from Mozambique. And I'm the psychiatrist and coordinating the program Pride in Nampula. It's a program that is from the Department of Mental Health in Ministry of Health of Mozambique and University of Columbia in New York. And thank you for inviting us.
Thank you, Antonio. Looking forward to engaging with you in this discussion. We also have Ken Carswell from the World Health Organization. Ken?
Hi there, everybody. I'm very happy to be here today and looking forward to this interesting discussion. So I'm Ken Carswell. I'm a mental health specialist with WHO in Geneva, where I work in the Department of Mental Health and Substance Use. And I'm focal point there for digital innovation and psychological interventions, where I lead our work on developing self-help interventions for mental health. Thank you very much.
Great. Thank you, Ken. And Roy, would you tell us a little bit more about who you are?
Yeah, hi, good morning, good afternoon, good evening to everyone. My name is Roy Dahil. I'm a public health and health informatics graduate. In 2016, I co-founded Mental Health PH. We're a non-profit organization promoting and raising awareness on mental health in the Philippines through social media and digital technology. Thank you so much for having me here. I'm excited to learn from our panelists today.
Thank you, Roy. Last but not least, Jaina, and then Patty.
Thank you so much. Hi, everyone. Nice to meet you all. My name is Jana. I'm a UK-based psychiatrist and public health doctor. I'm currently in Rwanda with YLab. So we are a youth-focused digital health organization, and we create co-designed interventions for young people, primarily in low and middle-income country settings. I work as technical lead, so I oversee design, implementation, and evaluation of our programs. And yeah, I'm really looking forward to today's session. I'll hand it over to Patty.
Hi, everyone. I'm Patty Gonzalez. I'm from New Delhi in India. I am a youth mental health researcher and a public engagement specialist. I work with Sangat, a mental health research organization, which designs mental health innovations across the lifespan, but these are specifically those that can be delivered through task sharing approaches. Yeah, really excited to be here and look forward to the discussion and hearing from everyone in the audience.
Absolutely. Thank you so much to all of you for those introductions, and let's get right into it. And Roy, I'll start with you. I'm interested to find out, from your experience working on digital mental health tools in Philippines, how can these interventions be utilized to provide rights-based, person-centered care for people dealing with mental health challenges?
Yes, thank you so much, Mulevs. I think I just want to begin the session by saying that going digital and digitalization is, I think, inevitable. This is an idea that many people might have realized during the pandemic. So instead of asking whether digital technology is a friend or a foe, we really need to start asking and answering the questions: how do we make it safe, accessible, responsive, and inclusive to everyone? In the Philippines, digital technology has been leveraged to improve access to certain mental health services through telemedicine. For example, telepsychiatry, telecounseling, and teletherapy, crisis hotlines, and mobile applications initiated both by the government and non-government agencies. Our nonprofit organization, Mental Health PH, for example, is developing and testing 2 mobile applications. We call it Gabay, or that's in English, that means guide, that targets or aims to help persons with anxiety and depression, and Sibol, or in English, it's Sprout, that aims to improve well-being of general public. During the pandemic, we developed and released mental health chatbots to help triage service users, asking our social media pages where to get help, and a website directory of mental health facilities in the Philippines. And from what we learned in the development of these digital technology solutions, an important aspect that we keep on doing is involving the service users not only as recipients, but in the beginning and in developing of these mobile applications, making sure that they are at the front and center of these developments and not just mere recipients of technology. By doing this ensures that interventions we're working on are contextualized, effective, and appropriate to the needs of the service users we are targeting it with. And I think I'd like to close to emphasize and remind everyone that when we talk about digital mental health and thinking of digital interventions for mental health, we should not limit ourselves to clinical interventions alone. As a public health graduate, prevention to illnesses is equally important. So might as well we leverage this digital technology, and how can we use this to raise awareness, educate, and address stigma and discrimination, promote healthy practices to maintain well-being in the country. So thank you so much, and excited to learn from other panelists in this session.
Thank you so much, Roy. And what an important point there around creating solutions that cater for the service users. Thank you so much, Roy. And now we'll move on to Dua. Dua, what are some examples of successful digital interventions in Pakistan? And what challenges did you face when implementing these tools?
Thank you so much, Olet. And I'd like to start by seconding everything Roy said. I think it's inevitable at this point that digital interventions, not just for health, but in any other aspect of life, it is very, very crucial, and it's important that we integrate it in our systems. So I'll start by giving a little bit of context of the Pakistani landscape. So in Pakistan, there's a serious dearth of mental health experts for service provision, with like a recent informal study suggesting that there are around 3,000 psychologists and 500 psychiatrists for a population of 200 million plus people. So that is a huge gap that exists in our landscape at this point in time. So post-COVID, what we realized and what we started seeing is that the trend of health provision or health service provision changed quite a lot because everything shifted to digital. And since then, the trend for telemental health services has started in Pakistan, and Taskeen itself obviously offers telemental health services. There are a lot of organizations, private organizations and public organizations that are offering these services. Now, what this really helps is bridge the gap of affordability and accessibility, because what we have seen since 2019, earlier 2019, when we started the helpline, was that people who are in the most remote parts of Pakistan, who probably do not have access to the internet or a smartphone, what the helpline does is bridge that gap and make that service available for them. And what we've seen is a lot of minorities have been able to take a lot of advantage from such services. So we're talking about youth who do not have access to, let's say, to go to a psychologist or a counselor without, guidance and stuff. Or we're talking about women who are at home and who cannot leave the confines of their home to go seek help or just, talk to someone. So those kind of, target groups, those exist, and those are realities in every region in the country. So it really helps to extend that kind of service to them. And we've also interestingly realized that a lot of expats, and we're talking about blue collar expats that are not in Pakistan, they also use these services because they need contextually relevant kind of service provision, because obviously you can't expect someone like to understand the kind of issue. So they do refer to our helpline to get in touch with us. And another interesting thing is that the government is also taking a lot of interest in this, and they want to probably in the near future start a national telemental health service or a hotline for that. Another interesting intervention that I would like to talk about is that earlier this year, we started an AI WhatsApp chatbot. So what the chatbot does is that it provides its service as a screening tool and also as an appointment booking system. So initially, when someone would contact us, they would have to go through a helpline coordinator, asking them details about where they're from, their age, etc. Now, all of that system has been digitized. So anyone who wants to get in touch, the WhatsApp chatbot gets all of the details. So their name, the region where they're contacting from, their gender, what they want to know. So all of that has been digitized, and it actually has accelerated the process of service provision. And we've also introduced recently a suicide basically ideation screening as well. So anyone who's come in with suicide ideation is booked for an urgent session right away, because depending on the severity of the situation. So that in itself, I think, is one of, it's a great intervention, and we want to expand it to other kind of public organizations too. Other than that, I think one of the most important things, which I think is available to everyone, is social media. And I'd like to talk about this because social media is everywhere, and it is very important that we make use of it to talk about mental health. And what we do here at Taskeen is that we do a lot of creative storytelling. So we communicate about mental health and mental health awareness and the psychosocial determinants of mental health distress through creative storytelling, and also by highlighting the experiences of people with lived experience. And this is something that I think is very, very important in the landscape of mental health, is to talk about people with lived experience, because the experience that they bring in to the conversation is unmatched. And it really, what we've realized, it creates harmony. It brings people together. We've had a lot of people who've come in to us and told us that we saw this story and it really helped us feel that we're not alone in this journey. So those are some things that we're doing, and I'm happy to be talking about this. So yeah, thank you.
Wow, thank you, Dua. So interesting to hear about all the great work that's been happening on your part in terms of the interventions that your organization has put in place to assist people with mental health. And really great to also hear you acknowledging actually that there's also a large part, of the population that's still without access to the internet. And they also have to be taken into consideration in terms of mental health interventions. Thank you so much for sharing. That was definitely interesting to hear. And let me now move on to you, Dr. Jenna. What are some of the key takeaways and recommendations from your latest systematic review on digital mental health interventions, particularly in low, middle income countries?
Thank you so much. Yeah, so I think just to briefly speak about this review, so we looked at the evidence base around the efficacy of different digital mental health interventions, specifically looking at those that are focused on young people. And we know that young people are disproportionately vulnerable to developing and being affected by mental health conditions. And as some of the other speakers have alluded to, there's a huge gap in care and treatment, especially in resource poor settings. And digital mental health interventions can potentially circumvent these. So yeah, I carried out a systematic review, and very briefly, we found 7 studies that fitted our inclusion criteria. The main findings were that digital mental health interventions that were culturally adapted were effective. So specifically looking at some certain methodologies, for example, CBT-based interventions were really effective. And specifically within those that have targeted certain mental health conditions such as depression, anxiety. So we know that there's an evidence base, albeit small, that shows these interventions can help young people's mental health in these resource poor settings. But we also found that a lot of these studies were of poor quality. There was a lack of culturally adapted mental health interventions. And also data was severely lacking. I'm sure most people are not surprised by that, but I think it was really useful to sort of to formally lay that out. So in terms of implications, I think there's 4 main implications that I kind of wanted to speak about. One is design. So from the work that we do at Y Labs, a lot of our work is, well, I think all of our work is actually built around co-design. So we design with and for young people. And I think that integrating young people's perspectives and community perspectives in the design of these interventions is crucial to making sure that they're clinically effective, acceptable, and also sustainable. And there's quite a lot of research evidence to show that this is the case. Secondly, there's a huge need for data generation and collection around these communities, and also co-design can be a way of doing that. Thirdly, ways of working. I think digital mental health in general, really relies heavily on cross-sectoral partnership building. So with communities, but also with policymakers, with clinicians, with a whole host of different actors to making sure that these interventions are really effective, contextually effective. And fourth, I think there's also a space for regulation as well, regulatory mechanisms that make sure that community perspectives are at the heart of innovation in these settings, and making sure that they're culturally sensitive and adapted for these vulnerable populations. Very briefly, we've taken some of these learnings and applied them to the work we're doing. So I won't go into this in much detail, but we're scaling an intervention called Tigere Jaheza, which is a digital mental health literacy chatbot tool. We piloted it in Rwanda with 2,000 young people, found it worked at the pilot stage. and we are scaling it to hopefully impact 100,000 young people in 12 different regions of Rwanda. So that's one project that's being impacted by these findings. And then secondly, we're also working on a USAID funded intervention in Tanzania, improving the quality of mental health sort of learning and referral skills of community health workers in 3 different regions in Tanzania. And we're working with 250 healthcare providers. So both of these projects are influenced by this review, and hopefully it sort of creates a space for conversation and sort of further action. Thank you.
Thank you so much, Dr. Jana. Really fascinating to hear, as you were just touching right now, on the work that you've been doing in both Rwanda and Tanzania. So hoping to see the social impact that both of those social interventions or mental health interventions have, particularly in those 2 countries. And just a reminder to our audience that you have the opportunity to ask our panelists questions. So we do encourage you to send those questions in the chat window or in the Q&A window via Zoom. So next I will move on to Patty. Patty, I think what I'd really like to find out from you is if you can share any specific strategies or insights on leveraging digital platforms to bridge service gaps and address stigma surrounding mental health, particularly among adolescents in India. Could you share a little bit more about that?
Yes, thank you for the question. Just to give a little bit of context for where we work in India, there's a very high prevalence of mental health problems for young people, and suicide is the #1 cause of mortality for youth. And there's a very large care gap, similar to what you heard, for example, in Pakistan. So it's about 90 to 99% for adolescents, which means that most young people who need help are unable to receive it. And challenges are both on the demand as well as the supply side. So, for example, addressing concerns about the very limited mental health workforce and infrastructure, but also stigma, which is a huge barrier to young people accessing any kind of support. I'll be sharing just a couple of examples and highlighting sort of 5 lessons we've learned through some of our digital mental health research studies and programs we've designed. These are focused on prevention and early intervention. Now, using similar approaches you just heard about, so particularly co-design and sort of very involved youth engagement. And as you just heard from Dr. Jana as well, one of the reasons for developing these in this way is that, as he pointed out, there are very few digital mental health innovations designed in LMIC contexts, which are culturally congruent, which have been co-designed, and very, very, very few have been evaluated. At Sangat, we have designed digital mental health initiatives to address mental health in schools. So, for example, using technology like apps and games to study whether it was feasible to deliver an early intervention program that was teaching problem-solving skills to high school students to address depression and anxiety. Similar also to what you heard from Taskeen's work in Pakistan, we've also been for the last about 8 years now running a very large national campaign called It's Okay to Talk, where we've been implementing anti-stigma work through especially personal narratives and stories mixed with media and psychoeducation resources. And at the time that we launched this, it was the first campaign of its kind that had actually sort of collected youth voices and was using and promoting youth voices as the main content. This program has reached sort of many thousands of people in person and about 25 million online. Building on this campaign more recently, we are developing an intervention for young people in schools and universities who are experiencing depression or anxiety called Baatcheet. Baatcheet means conversation in Hindi, and it's taking the stories that we've been working with and putting them into a sort of personalized, peer-delivered digital storytelling intervention that can be accessed by students in schools and universities. There's a range of other programs for other age groups in early child development and adults as well. At Sangat, happy to share information or links to publications in the chat if anyone's interested. Now, the 5 lessons quickly on this, and I won't sort of retell the ones that you've heard more about. But the first is that, co-design, meaning very active collaboration between researchers, designers, young people, including applying lived experience. It's really, really critical for developing something that a young person likes and is going to find useful. The second is, and it's related, is, involvement is quite a varied term. And I don't think there's an operational definition still for what youth engagement is. But, how do we actively involve youth and share power as, even those of us sitting on a panel like this who routinely design these kinds of programs, but share power throughout that research life cycle. And this could, at a practical level, mean including young people before you start your program or your study, or involve them in writing up the proposal or the grant. Make sure that there are dedicated roles for them throughout the program, whether this is governance, conducting or analyzing the research, evaluating it, disseminating or scaling up. Being really honest about what is feasible, and there's always resource limitations in projects like these, and establishing collaborative activities where young people get to have a final say or a final sign-off, and being very flexible with regards to how young people are involved. The third is to involve diverse groups of youth. Again, a very, I think, complex term, but meaningful youth involvement means listening to, as many different voices and paying very special attention to marginalized or less heard voices within the youth population. And also, I think, acknowledging as organizations or researchers, we will never be able to capture, the complete spectrum, but identifying lived experience, which accounts for factors such as age, gender, sexuality, ethnicity, geography, disability, or types of severities of mental health problems is a really good place to start. And finally, I think understanding that, minority groups themselves are also super diverse populations. So, thinking through appropriate sampling strategies when you're looking to involve young people. Fourth, and I think, we heard about this a bit, which is the context of design itself. So we already know about, there are many barriers to accessing digital health in LMICs or just lower resource settings. So having a focus that really builds these equitable partnerships and highlights the structural conditions of young people's lives. So for example, showcase and depict relatable contexts or situations, showcase different risk factors that are relevant, whether it's migration or war or low socioeconomic status, etc. And the last one, which we heard about, but which I think has become even more real to us, even though we develop, at a research level, but is to plan for sustainability before the project starts as early as possible, and begin this in the design thinking phase itself. Because I think, there's increasing research that most digital mental health interventions don't actually make it into real world settings. They stay in research labs and universities. So this might mean working directly with that intended stakeholder or the setting, and letting the real world determine what decisions you make. And if you feel, this is not sustainable, this actually can't be scaled up, maybe you want to reassess your methods or the direction that you're taking. I'll stop there, but thanks again.
Wow, thanks so much. Thanks so much, Petty. You've really said a mouthful, but what I really like is that the one thing I keep hearing, I think so far between our panelists, is the importance of co-designing interventions taking young people in mind, but also taking the cultural and socioeconomic context placing it as a critical factor in coming up with these ideas and these interventions around helping young people and helping people with mental health challenges. Thank you so much. And I think now we'll move on to Antonio. Antonio, I'm really curious to find out, in Mozambique, have you recently developed and actually implemented a new e-mental health wellness tool in Mozambique.
Yes.
What have been some of your key learnings and recommendations, and would you, what would you share with others regarding that?
Yes, thank you for inviting us again. I will apologize first for my English. Mozambique is a country that speaks in Portuguese and has 30 million inhabitants, of which 70% is rural, and is the fourth poorest country in the world. So the other thing I will apologize is my internet connection. So I prefer to not having the video. We find out that if we save on the video, we have better audio communication. So about that, the Fica Bem, I first would like to explain and talk about a little bit about how we fill it up our pyramid, like with for 30 million inhabitants before Pride, we had only a few psychiatrists when we start Pride program between the Ministry of Health of Mozambique and Columbia University. So, and we had after that a few psychiatrists. We have this on our system on the middle of the pyramid. We had our psychiatry technicians. And I will stop a little bit there to tell you about the task sharing, which was a group of technicians that we built in our mental system from the Ministry of Health, because after the colonization after our independence, we went to a civil war for many years, and we didn't have time to train and form medical doctors and also specialists. So we made this task sharing in 1993, that we built this level of psychiatry technicians, and we have so far 350 that we will train them after high school for 2 years, and they were the ones who were delivering mental health. But so far, until before Pride, until the district sites level, not at the community level yet. So when we agree on Pride, and I'm happy to see the architect of all these plans, Dr. Lydia, is here. She is the former mental health department, I can see on the attendees. And Milton Weinberg from Columbia University, they are the architect of these programs. The main thing of this pyramid is that that pyramid belongs to the Ministry of Health. It's not a program that was installed and then Columbia University go and like happens a lot, right? And the program shuts down. No, it's a program that belongs to the Ministry of Health. The pyramid is the base formed by the community health workers, and then the primary care providers, and then on the top, the psychiatry technicians and the psychiatry Pride. We on the D40T4 grant, we change a lot on this system, on this pyramid, and we start to expand from the hospitals where the psychiatrists that were just 20 until lately, like last week, we could train and specialize 4 more colleagues. We are now 24 or something. And then we could go from the hospitals to train the technicians, psychiatry technicians. And now we are training the primary care providers and the community health workers at the community level. Also, we had on this D40T Fogarty grant changing on PhDs, which means that we have now 8 PhDs and 10 more to come. We start how this mental wellness tool works, which we call in Portuguese Fica Bem. Fica Bem in Portuguese means be well or stay well or something like that. So mental wellness tool, it's 13 questions that we make, and easy questions. 3 of them, the mental health provider or the community health worker goes to the household and asks 3 questions. Those 3 questions, it's about all the members of that family that the household can respond. We will find 73% of sensitivity for any mental health problems. And once we identify by proxy the member of the family that have mental health or substance use disorders, these 73% of sensitivity on that member will change and go up very good in 94% of sensitivity. With the same 3 questions, we will identify the member first of the family, asking these 3 questions to the household. And then when we identify this member, the sensitivity goes up to 94%. And then we make the other 10 additional questions that will give 4 categories of disorders, mental health disorders. One of them is severe disorder, and then the other one, suicide risk, and the other one is alcohol and substance abuse, and the other one, the 4th one, is common disorders. So, and after that, the severe disorders will be going after the diagnosis, will go going for the PCPs, primary care providers, that are trained already to medicate them and test them again if it's necessary. The suicide risk, the community health worker will be trained next year. It's the only package that didn't train yet to say on safety plan and having an intervention for 1 to 4 sessions. And then alcohol substance abuse, we're trained already on motivational interviewing and expert. It's 1 and 4 sessions. And then common disorders, depression, anxiety, and traumas with interpersonal counseling, which is 4 sessions, 1 a week. So it's how in a few minutes could explain all this system that we are implementing in Nampula so far. Thank you.
All right, thank you so much, Antonio, and hoping in the near future we'll be able to hear more about how that is going. Thank you so much for sharing. And Ken, from the perspective of the World Health Organization, does WHO have any recommendations concerning digital mental health tools, and how do you see the space evolving over the next few years?
Great, thanks, Malebs. Yeah, I just want to firstly say it's been amazing to hear these examples of real-world implementation from fellow panelists. It's very exciting because it is an area that's changing and growing and has a lot of potential. And I see very much, our role at WHO is very much to support some of these sorts of initiatives with sort of guidelines and tools and similar. So I'll talk a little bit about some of that now. So at WHO, something we did recently was we updated our recommendations for the treatment of mental, neurological, and substance use conditions. And these are treatment guidelines that cover all forms of treatment. But in this update, there was quite a focus on some of the conditions on digital. And this included both self-help, both guided and unguided, and I'll say a bit about that in a minute, as well as delivering interventions, perhaps over video conferencing and similar. And we found some new updated recommendations, including around self-help and digital interventions for alcohol and substance use conditions, anxiety, PTSD, self-harm and suicide, for people with suicidal thoughts particularly. And these recommendations supported some of our existing recommendations that showed that self-help can be effective for depression. So I'd say what we're seeing is increasing evidence for the benefit of these types of interventions. Now, the strength of them may vary. So, for example, we know that if you provide guided self-help, so you provide self-help information with some sort of coaching from a trained non-specialist, sort of using a task shifting approach, we see that that's generally more effective than unguided, though we also know that unguided has a very important role and is also effective. And particularly these things are useful, as we've been hearing here, that they can be provided across whole populations. So that's one area of the recommendations that we've come up with. We'll also soon be publishing a psychological intervention implementation manual, which provides implementers with some of the advice and guidance on how you actually implement primarily psychological interventions, including something that's been mentioned a lot here, which is around cultural and contextual adaptation, co-design, and similar, which are really important aspects for engagement and design of intervention. Now, alongside all of this, we've also been working to address one of the gaps, which was mentioned, I think, by Patty earlier, which is that, there's a lot of research out there that shows us that these interventions are effective, but as an implementer, if you want to set one of these up, sometimes those interventions aren't available. They might stay with the researchers. So we've been trying to address that by developing and then testing in big randomized controlled trials, different psychological interventions and different self-help interventions, and then publishing these as open access. So the aim here is really to do the initial testing, develop content that we know works, and then others can take it, adapt it, improve it, and so on. And we've had a lot of success with this. And one example is a digital intervention we designed for depression called Step by Step, which we tested in randomized controlled trials in Lebanon with Syrian refugees and with Lebanese and other populations there. We had two separate trials, and we showed it was significant, very good effects. And the Ministry of Public Health in Lebanon have now scaled that as a national service that's available to anybody throughout Lebanon. And that brings me on a little bit to what we see might be, or what I think would be important for us to sort of work on and develop over the next few years is really starting to try and focus now on implementation and models and understanding how we can effectively provide these sorts of interventions at scale. Now, this also includes how do you fit it within a health system? Because I think, again, as was mentioned earlier, digital is a useful part of the service mix. It can't ever be the only part. It is part of a mix of services. So how do we start putting together things like self-help and digital interventions with in-person interventions? How do we provide people with support who requires more support? So I think they would be some of the really interesting areas that I'd like to see develop over the coming years. And obviously, there are many other aspects as well. I mean, technology is evolving so fast that we see there might be potential for things like chatbots and AI. They might be more engaging for people. So again, how might these new technologies help mental health systems and different organizations with responding to need really across the continuum. So really, how can you use these both for providing things like self-help, but also how can they improve health system understanding? How can they improve identification and so on? So I think there's as other panelists said, things are going digital. They will continue to go digital, and it's about how do we make it safe and as effective as possible. So thank you.
Thank you, Ken. A good point, well made, around how do we make it safe and how do we make it accessible for people. Thank you so much. I'm conscious that we are running out of time, so I just want to quickly go through some of the questions that are coming through, and just a reminder to our audience that if we don't get to answer some of the questions, we'll definitely have them answered on Circle, which you can join right after the session. So the first question that I see is from Mahira, who wants to find out from the panelists, what are you noticing about the needs of youth mental health in terms of data? For example, the types of trends showing up in respective programs. In your experience, what is the level of seriousness of engagement by educators or administrators or regulators? Any one of our panelists that wants to answer that? Sure, Ken. I think you can go ahead.
Sure, I think Jana had his hand up actually. So Jana, if you'd like,
okay. Go for it, Ken.
Go ahead.
I'll over to you.
Okay, thanks. I mean, I think Jana will have some good points as well, given the recent systematic review. I was going to say, I mean, we covered this in in WHO World Mental Health Report that was released, and we are seeing increases in concerns around youth mental health. I think they've been there for a while, and we're seeing increasing concerns around this. So it's certainly something that I think is becoming clearer, and has always been clear that there are concerns around youth mental health. The causes for these, there are many. Particularly in the digital space, there's obviously some concerns around social media, around engagement with digital, what sorts of problems might that cause, as well as the wider social determinants and other problems that we might see. I think whether these are the degree to which these are increasing or not might be sometimes a bit of an open question, because the evidence does sometimes seem quite mixed, and it might well vary between the different places. So I think it's something that we'll hopefully get more understanding of as we move forward, but it's a very important question. I mean, and I think we could even say, in terms of the seriousness and of engagement, I mean, I think what we've seen from this panel really is that youth was mentioned a lot. It's certainly something that is, I think, very much on people's minds, and we're seeing, I think, increasingly an interest in this area and seeing the importance of this. And this is also leading to the development of new interventions and support for these groups. Thank you.
Right. Thank you, Ken. Dr. Jenna, did you want to touch a little bit on that?
Yeah, I mean, just to add to what Ken says, I think from a data perspective, we know that smartphones or sort of internet connectivity is increasing, especially in a lot of these emerging markets, and we know that young people are very much using these devices to find out about mental health, but also they're operating in a context of high levels of stigma, shame, and also if we think of mental health as not just being in a silo, we're also seeing this sort of played out in sexual health, reproductive health conversations as well. So I think in terms of data, I think that my review found that there isn't much formally sort of collected data, but I think one of the exciting things in terms of the work that we're doing both at Y Labs, but I think a lot of the people on these panels and also within the broader conversation around tech is that we are generating data in different ways. So the academic, more formal, rigorous methods of collecting data are great, but I think that we could also think more creatively about how we generate data if we think about co-design methodologies, but also other ways of collecting data around young people's mental health and engagement with different types of channels and platforms that may feed into this and may sort of create a platform for more sort of formal, long-term, rigorous academic work in the future. So I think also thinking more broadly about data collection, and also very briefly, I think data collection is also key because it informs a lot of the effectiveness of these interventions. So I know within the AI space, there's a lot of racial bias within the data sets that are used in high-income country contexts, and we need to make sure that if we're going to be using these technologies, both for marginalized populations in high-income countries, but also for people in the global south, that we need to ensure that the fundamental data sets that we're using are diverse and representative of these populations. I think that's a really important question and conversation for the future, for now and for the future. So
absolutely, absolutely, I agree. And thank you so much, Dr. Jenna. I'd like to pose this next question to Dua, because Dua, earlier on you touched on AI and WhatsApp chatbots as one of the interventions that your organization has been working on for mental health interventions. We have a question from, and forgive me if I'm mispronouncing this name, I think it's DT, and DT wants to know how a current digital mental health interventions, especially AI-based, managing crises like thoughts of suicide, violence, and so on. Dua, would you like to touch on that?
Yeah, thank you. That's actually a great question. The first and foremost thing, if I talk about AI chatbots, the first step would be integrating it in the algorithm. So it cannot be an afterthought. It has to be integrated into the algorithm, and there are quite a few suicide screening questions and tools that exist, and I can actually link a few of them later on, and maybe you can share those with Jyoti that you can look into. And apart from that, what is more important is having an integrated system with a service provider that is on ground. So for example, in most cases, if I talk about Pakistan, for example, it has to be working with the government hospitals that are existing. So the system needs to be integrated in a way that any query that is raised can ultimately go to the right kind of service provider. So I think that is very important when it comes to not just suicide, violence, homicidal cases, and yeah, mainly suicidal. Yeah, I hope that answers.
Thank you.
The question.
I hope DT that does answer your question. And I'm just going to take one final question from our audience, and I really do apologize because we are running out of time. So we'll make sure that all of the questions that you do have, you will have answers via the circle that we've also shared a link for in the chat box. So another question that we have from Ciara is, what are some of the challenges in designing programs for youth in low-income settings? Any one of our panelists that would like to answer that?
I think I'd like to comment on that one. So from my experience, engaging on these spaces and collaboration, the availability of these spaces, decision spaces, and the accessibility of this one, especially in low middle income countries, as a youth before, we're having difficulty on knowing where these spaces are, where we can collaborate and share our insights, where we can learn, where we can also co-create these designs. So I think a challenge to most government agencies and NGOs creating these interventions is how can we make sure that we create this space, make this space accessible to the youth, and they can comment and share their what they want to see in these platforms.
All right. Thank you so much, Roy. And I really do hope it does answer your question, Ciara. As I said, some of these questions that have come through, we'll make sure that they are answered on Circle. Otherwise, I think as we now wrap up the session, I'd like to find out from our panelists in 30 seconds or less, to make digital mental health interventions a success, what is it that we must do? Anyone to get us started? It's quite a big question. Dr. Jaina?
I'll get mine out of the way. To make these a success, I think we need to center them around youth perspectives.
Perfect. And Patty?
Yeah, mine's quite similar. It is to involve end users at every stage.
Thank you, Patty. And Ken?
A hard thing to answer so briefly, but I think I would say to learn more about integrating and scaling through both research and practice.
Nice, thank you. Antonio?
Well, we believe in sustainability.
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 I love those one-word answers. Thank you, Antonio. And Dua?
I think ensuring safety and accessibility.
Safety and accessibility. I definitely agree. Any other panelists that would,
Firstly, to make digital mental health interventions a success, we must co-create, collaborate, and communicate.
Collaboration and communication. Love it. All right. Thank you so much. And I think as we wrap up this session, thank you to our amazing panelists today. I'm sure that the rest of the audience appreciates how insightful this discussion has been. I know that I do. I'm taking quite a lot away from this discussion, and I'll definitely be joining the circle to make sure that I engage with the rest of the audience, but also to hear some of those answers to some of those questions that the audience has asked to our panelists. Thank you again to our panelists, as well as you, the audience, for being a part of this critical discussion today. The next webinar is scheduled for January 2024, and the topic will be on the health workforce. The registration link is also in the chat, so make sure that you do register for that event as well. Otherwise, just another quick reminder that we do have another session later on at 2 p.m. GMT to accommodate people in different time zones. And I'd like to encourage you again to continue the conversation on Circle right after this. And as I said, the link has been shared with you. Otherwise, follow United for Global Mental Health or the Global Mental Health Action Network on social media platforms so that you don't miss on any of these types of events in the near future. I think that's it. And thank you so much, everyone, for taking your time today and having a meaningful and insightful discussion. Thank you.
Thank you. Obrigado.
Thank you very much.